This week on the BackTable podcast.
For me, coming as an IR doc, some people are going to be like, why the hell would you join forces, with a vascular surgeon? And I'll be honest, I mean, there's a huge benefit. Like I said, I got to see it firsthand in my fellowship, but I mean, at least it happens every single week where I do an angiogram on a case or I get access and I'm going through and I'm like, you know what? I don't think this is a great endo revas case. I think we're going to end up jeopardizing future bypass options or treatment options. Well, then it's great for me as an IR doc because I've got a guy right here as my partner that we go over cases all the time, go over imaging, say, hey, from a surgery standpoint, what would you, what are your thoughts here?
Hello, everyone, and welcome to the BackTable podcast, your source for all things IR and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, Stitcher, and listening platform of preference. This is Aaron Fritz as your host this week, and I'm very excited to introduce our guest today, vascular surgeon Dr. Jim Melton and interventional radiologist Blake Parsons, coming to us from CardioVascular Health Clinic in Oklahoma City. All right, so before we dive into our topic today, just want to say a quick word from our sponsor, RadPad. RadPad was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information. Contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And let them know you heard about it on the BackTable podcast. So let's get into the episode. My goal with this episode is to cover pedal access and hopefully inspire others to learn how to do it, but also to talk a little bit about how IR and vascular surgery can successfully work together for better patient care and possibly even a better, business or practice model for a lot of the IRs coming out of training, especially for the more clinically oriented trainings coming out of the new IR residency. So first off, I'm going to just ask you guys to tell us a little bit about yourself and how an IR and vascular surgeon linked up to tackle vascular disease together. I'm going to start with you, Jim.
Yeah, so we, my partner and I that started CardioVascular Health Clinic, we initially had, we were the initial 12 guys in Oklahoma City that built two gigantic heart hospital systems that were physician-owned and partnered with Mercy Systems out of St. Louis, but and they were a decent partner. We did that in 2002 and pretty much dominated the market with about 15 to 1,600 pump cases a year and about 1,100 open vascular cases a year and a lot of percutaneous work. So we pretty much we brought three different groups together from three different hospitals and did that deal in 2002, and then we built another one pretty much identical to that one on the south side of town. So and that was that. But in 2012, 13, it became a place where, if it makes any sense, it became the place that we left, if that makes any sense, because it just came too administrative heavy and couldn't get your stuff done efficiently like we started. Initially, that's why we left and built the place. So in 2015, we left and built CardioVascular Health Clinic, and what's been amazing, is just the ability to make this hybrid facility, surgery center, a JACO-approved surgery center, accredited surgery center, and OBL has worked really well for our practice. I'll let Blake talk, but Blake contacted us in probably late 15 or early 16 and was a total surprise to me. I knew of his father because his father had practiced in Oklahoma for a long time as an internist and knew of his upbringings and reputation and all that. So I knew he came from good stock. But it was really strange to think that, an IR had the entrepreneurial vision that he had at such an early age, because he didn't want to work for a hospital, and man, it's been a great marriage, if you will, together for our practice, because he just adds so much different skill set and different procedures that work perfect in the OBL space or the surgery center, depending on contract negotiations. So that's where I first met Blake himself. Is in probably late 2015. I was a little worried about the clinical skills of IR. When I was working, they just they were proceduralist only, and when he got out of his fellowship, I was extremely impressed with his ability to run a clinic and clinically be sound as far as deciding what patients need, and also politically correct with referrals and everything like that. So it's been a great experience for us, and obviously looking to grow that side of the business with another IR or two for sure. So it's been great.
Yeah. So it was, I think, early 2016. So I did my diagnostic residency at OU, University of Oklahoma. I guess I was right in the fellowship match. And so ultimately I was extremely fortunate to be able to match at the Medical College of Wisconsin there. But I always, I guess, for some reason through my residency, I always knew I wanted to have kind of a outpatient-based practice. I guess it's maybe, like you said, kind of the entrepreneurial spirit of the whole deal. I had just kind of randomly during residency, one of our techs actually got hired on here at CardioVascular Health Clinic, and she said, "Oh, you'd probably be interested. There's this vascular surgeon and a interventional cardiologist that built a place, and it's kind of what you've been talking about." So I said, "Oh yeah, sure, this is going to go over well." So yeah, give me their email, and so she gave me Jim's email. I emailed him basically saying, that they should hire me, and send him a bunch of CPT codes, I think, about how much money I could make them. I don't know. I figured this was gonna not go well. So, but to my surprise, I think by the end of that first day that I sent it, they'd already emailed me back and were like, "Hey, we're super interested." And we set up a meeting, and they definitely took a chance on me because, like you said, they had no idea really how this was going to play out. I still hadn't even gone to fellowship yet. So they obviously, I graduated from fellowship at MCW in 2017, and now we're going on 3 years here. And it's been great. Like I said, I was very fortunate to go to MCW, which I believe is one of the top programs in the country, not only just because we did a lot of peripheral arterial work, but we did get a lot of exposure to clinic, like he said. We did a lot of clinic work, and we just got a very broad view and training. Got to pretty much do everything there. So when I got back and joined the practice, obviously being able to join a guy who's been doing it a long time and has a great national reputation and is one of the best surgeons in the nation. That's been awesome as a mentor as well, and well, I'm sure we'll get into it too, and kind of as a partner from a different specialty to be able to bounce things off of.
Yeah, so that's interesting that you had that foresight, Blake, to think that this would be a good a nice partnership. The way I met you guys was I was very fortunate to be invited to drive up from Dallas and watch you guys, because I was interested in learning more about pedal access, and watch you guys perform a number of pedal access cases. And I was just really impressed by the facility and the number of cases, the volume of cases, the variety of cases that you guys were doing. Just real quick before we jump into the pedal access topic, can you tell us a little bit about how things are holding? Because that was back in January, February when I drove up. How have things been since the COVID-19 pandemic?
Yeah, so it's obviously been interesting. Our number one goals as a business were to protect our employees and our patients, as everyone were, and so we took policy changes immediately and did all the things that everyone is doing with temperature checks and background checks as far as where you've been and if you've been sick and all that stuff for every patient in. We also keep the families out in their cars and limit the patients' volume in the waiting room and all those kind of normal things. But we were kind of instructed through a separate call from administration of in Oklahoma to they didn't understand our surgery center and what we offered, and we're very happy to hear that they could offload some of the hospital volume in a COVID setting to our place and get it done in a efficient manner, the way we do it every day. But so we haven't been down like most surgery centers, and that's the reason, is because of the pipeline of business that we have. Those people continue, as you know, Aaron, they continue to get sick, and they ignore their health because they're afraid to go to the hospital. And we can have numerous cases of people staying home too long and having big MIs or losing limbs because of their fear of the hospital. So it's been the governor and the state health department people have really been supportive because of that. We're able to do PCIs, we're able to do devices if they need them, and we're also only emergent devices only until the last week or so. And also, obviously, our critical limb ischemia practices really haven't slowed down at all. Blake and I have we just do, obviously, most of our practice is gangrene and ulcers anyway. So that's what we've been doing, and hopefully making a difference in people's lives, even in this terrible situation we're in. So,
yeah, that's great. That, like you said, there's a lot of anxiety about patients, going to the hospital. I was trying to get a patient to get an IVC filter out, and he refused because he didn't want to go to the hospital. And so, there is a lot of anxiety about that. And so that's great that you guys are able to offer that. Blake, how about stuff like fibroid, UFEs, some of the more elective stuff? Has that been curtailed?
Sure. Yeah, exactly. We stopped all true elective cases, kind of on par with regulations. So just like you said, we've only been doing, urgent, emergent type cases, emergent as you can be in an outpatient setting. But yeah, so mainly everything we've been doing has been peripheral on Jim and I's part, it's been peripheral vascular work. So like you said, we do have a lot of patients with ulcerations and wounds. And so obviously we still have been still performing procedures for those patients and trying to heal their wounds. Now, claudicants and all those, no. And that's a good time for them to continue doing their exercise programs and, conservative therapy. But no, so we've kind of, on the vascular side, it's all been primarily wounds and stuff. Now for the other, like you're saying, we have 3 interventional cardiologists that are partners at our clinic as well. So that's kind of what he meant by still being able to do coronary stuff and screenings and procedures for those people.
Yeah, and I forgot to mention that is the other unique thing about your center is, and Jim talked about it at the beginning, is this having cardiology, vascular surgery, and IR all under the same roof.
We have 3 people that hate each other also.
Yeah. But it's pretty amazing. And I imagine the level of health of patient care you're providing is unparalleled, in other parts of the country where there's a lot of turf wars. Sure. I just think collaboration is the way to go in terms of better care. And so hats off to you guys for making that happen. And so anyway, let's delve into the topic for today. Like I said, I learned a great deal from you guys when I came up there. But I want to take a step back before we get into the details of technique of pedal access and ask Jim, what inspired you to first start trying pedal access, since it is a relatively newer technique. How did you learn it, and how long did it take you before you felt comfortable?
So over at the Heart Hospital in 2013 I started sticking, like if I was going to try to get through a TO with an ulcer of an SFA or something, and I got tired of not getting all the way through it, or even trying, even being able to get past the proximal cap at all. And so I just started sticking pedals with ultrasound guidance, which, as you know, a vascular surgeon's interventional radiologist is the best by far at that. No questions asked, period. And then, so, I mean, it was a skill I had to learn. And so I learned that and just stuck just small needles and put a wire in just so I could know I could do it. And then I said, well, you know what, let me try to get through this distal cap. And it just became very obvious very quickly that distal caps are so much softer than the proximal caps. And a lot of times you just fly up with not a lot of product cost involved. And you're able to save a bypass for another rainy day. So I think that, at the end of the day, it was that really got me started. And then we just started sticking more in 2014. And then I left in 2015 and our center is, my practice alone, Blake's is a little bit more, he does some crazy IR stuff that, I don't do sometimes, but my practice is probably 98% pedal. I hardly ever stick a femoral or anything. So that's mine. And so that's from 2015 to present. And I think Blake's practice is starting to reach that too, whether it's BK disease, SFA disease, or 3-level disease, including the iliacs. We just feel a lot better with just multiple things. I mean, we're trying to get a paper out for the radiation dose decrease is gigantic going pedal. Contrast usage is markedly decreased going pedal. And the put through, as Aaron said earlier, a put through of actual patients goes up about 2.6 per day if you do all pedal as opposed to femoral.
Yeah, it was impressive how many cases you guys were knocking out that day I was there. And so Blake, was pedal access something that you learned in fellowship? And maybe along those lines, tell us a little bit about how the transition was from fellowship to, working with Dr. Melton.
Sure.
Some of the stuff you picked up.
Yeah. Oh yeah, definitely. So, like I said, we did a lot of peripheral arterial work. We were fortunate, and this kind of goes back to me working with a vascular surgeon, and that at MCW, you kind of worked hand in hand with the vascular surgery program there. So I'd already had previous relation and saw how it worked during fellowship between vascular surgery and interventional radiology, and it was great, And so I kind of knew, this is awesome because I'm going to be able to take this same thing, the same approach, the same ability to work at patients, bounce things off of each other back to my practice. I would say we only did a handful of true retropedal, or what people call TAMI cases. Most of it, if when we stuck tibial arteries, it was because you're doing a safari or something of that nature. And I'd talk to Jim on the phone and he'd be bragging about how many retropedal cases he's doing and giving me a hard time. I was like, yeah. And then, sure enough, I got back and, my practice obviously was slow at the beginning because trying to get the general public to understand what the heck an interventional radiologist is just part of the battle. But I'd spend, I'd scrub into cases with him and watch him do cases. And sure enough, he a lot of retropedal access and just saw the ease, the decrease in time. I mean, we're talking complex multi-level leg, maybe an hour and a half typically. Like total time. I'm not talking fluoro time, obviously. I'm talking total time of getting in there and doing the case, significant reduction, like you said, in your contrast dose, patient dose, because you're not having to go up and over. You're not radiating the pelvis as much. So, I became a believer. And then obviously as my peripheral work increased over the past 3 years, I've like you said, I probably do 95%. Now there's still times I'll go integrate femoral or SFA or, up and over femoral. If I know it's all, pedal below ankle or pedal loop or something like that I want to get a better vantage point to. But yeah, for the most part, I also go retropedal from the foot.
So I guess to clarify for some of our audience, like you said, you're talking about safari technique where you're still getting access in the groin and in the foot. Would you mind clarifying that? Like what you guys are doing, you're just solely getting access in the foot in the majority of cases rather than getting dual access, right?
Sure. So we call it retropetal. I know the other name out there, they'll call it as TAMI, that you hear a lot. But yes, we're talking single access within a distal tibial artery, PT or AT, sheath placed, and then all treatment is done from that sole tibial artery access. And we're able to, like you said, accomplish that probably 95% of the time. So
Aaron, I can tell you my practice, since we opened in 2015, I haven't done one so far, even one. I think Blake's done a few just because of the extent of the disease or whatever, but I think that's
pretty rare.
Pretty rare, yeah.
Along this line, so let's go into how you guys approach a case. And, the majority of your cases are being done via pedal access because you guys have the experience and the confidence. But for somebody maybe new or, you guys get a lot of visitors that come through and watch you guys. And probably a common question is, what are the big contraindications to pedal access for you?
Yeah, so when docs come and come to the center and we have the opportunity to hopefully help them and give them a good, a good time while they're here, is we try to go through some of that stuff. But I mean, it all starts with a really good clinical exam, and that's what, again, I was a little worried about with not Blake, but IR in general. But Blake, like I said, he came from a program that had that, and it was really a pleasant surprise. So a good clinical exam with a handheld Doppler in the room, trying to figure out, where these lesions are is really the coolest thing that I do in clinic. I mean, I kind of walk out and I know pretty much exactly where this lesion is. So a good clinical exam. And then I also tell the docs that come and haven't done much pedal to go ahead and do a duplex below the knee and, visualize that the AT and PT, is open. So it makes them feel a little more comfortable sticking it, and or the interosseous, either one, any of those three vessels. But I think that's probably the best thing. And your first 100 cases or so, I would probably stay away from one vessel runoff. Blake and I both still to this day still do that a little bit. We probably, if we think it's a one vessel runoff case, we'll probably do diagnostic first with either a little antegrade dilator or something like that, or an up and over small sheath, and then decide whether we want to go primary pedal or not. But pretty rare on that. But I think that at the end of the day, once you get some under your belt, you feel more comfortable doing one vessel runoff also. But I think that just comes with comfort level and experience as you going down the road. I think it's a really good way to recanalize a lot of vessels below the knee that are totally occluded with the selection of wires, that we try to show docs if they come to the course. But I think at the end of the day, it's good for all three levels, below knee, obviously SFAs that have never dreamed of getting through, and then inflow disease also.
Yeah, and so for and a lot of your patients obviously are CLI patients, guys with wounds. Anything in terms of like where the wound's located, or do you worry about the access itself causing a wound?
We like to try to identify the wound, in the certain angiosome for sure, and try to figure out, which vessel is important to healing that angiosome. So that's part of that clinical exam deal on the front end, and we try to cover up all the wounds on the prep on the patient with and prep them out, if you will, and try to obviously stick away. Probably over 2,500 cases, of CLI cases now for sure. Probably I've never seen a wound caused by the perk stick that didn't heal or anything to date. Let's
walk through a typical pedal access case, assuming decent vessels, whether it be, AT or PT. Where do you like to stick for your pedal access?
Yeah. So first off, obviously we're obviously using ultrasound. So from an ergonomic standpoint, the PT is a little easier to work with, but obviously that it all is just based solely on which angiosome we're kind of going after, what's their kind of preclinical evaluation of what we think is open prior to getting in there. You can always be fooled by distal collaterals that reconstitute the distal AT, PT, DP, and you get a monophasic signal and you think it's open, then you get into the case and it's not. But so it just kind of depends. AT, obviously distal AT, PT, usually around the ankle. Just kind of depends. We'll stick a DP more distal. Obviously, you're a little limited more on your sheath size if you think there's more proximal disease. But I'll even, like he's saying, if there's a single, if I know or I'm pretty sure they've only got, say, a single vessel AT to the foot and I can't hear a signal in their perineal or their posterior, then I'll sometimes even just try sticking their occluded vessel and see if, how hard the plaque is, because what the worst, I'm not going to hurt it. Obviously, it's already down. So I'll stick it, and then it's kind of like a freebie. I can, as long as I can get up through that, then I can get up and fix everything from there. So yeah, it just depends. A little bit of it is, we do have a pretty good idea before we ever step into the room, but obviously you got to adjust on the fly some too.
Yeah. And so once you get access, walk us through a little bit, like, your step-by-step in terms of micropuncture set, sheath size, and pedal cocktail.
So the Terumo glide sheaths was what we used when we first started, pretty much exclusively. And, we found that those are really good sheaths. Obviously, they're high-end sheaths, high-end company, very good company. But I think that at the end of the day, they're not braided as much as you really need for pedal, because they kink a lot. This doesn't keep you from getting the case done. You just have to use a dilator a lot to back in and out. But I think at the end of the day, we found a Merit sheath, and now there's a Bard sheath that's are braided. The Bard sheath's marked really nice on the tip, and Merit sheath is a really good sheath too. It comes in a 7 and a 10 centimeter length. The Bard goes all the way up to 90, I think, but we don't use long sheaths. We just use short sheaths in the foot. But as soon as we get in a micropuncture set with a short needle, we use short needles instead of the long ones. It's just a little bit easier to not come out of the vessel when you hit it, and then you're trying to get the wire in. Hydrophilic type wire is usually better with a little bit of support on the back. All the micropuncture sets are a little different, so you kind of have to find the one that's a sweet spot for you. And so once we get in, we put either depending on our clinical exam, what we think is going on, we either put a 4.5 or a 5.6 Merit or Terumo or Bard sheath in. And then we put a cocktail in that's about 400 units of nitro and 3,000 units of heparin is what we use. We just haven't seen any advantage in using any other drugs in there like they do for a radial cocktail. So,
yeah, we don't put verapamil in.
So I think that's our cocktail, and then we usually take a shot with either very little, literally 3 cc's of dye below the knee, and then we go after it as far as what the clinical findings are and what we think we're going into, which is most of the time very ugly vessels.
Welcome to the South.
Yeah.
Yeah.
But yeah, I was just going to, from there, there's definitely certain wires. Everyone's got their kind of particulars based on that initial shot of, is it all below knee? Is it involving more proximal, and the below knee is not too bad? Then that'll kind of depend on what size system we go with, like with an 035 right off the bat or an 018, so we're going to start with an 035 glide. Or am I going to start with like a 018 command wire, and then obviously take it up from there, and we'll get wire excess all the way into the aorta. And then depending on patient's creatinine and those things, we'll either do an angiogram through the catheter back down the leg, as well as obviously we are very strong beliefs in using intravascular ultrasound. So that's kind of our next step is then intravascular ultrasound. Not only we can see the extent of the lesion, but also so we can see, get appropriate size measurements for vessels for both angioplasty as well as potential stenting and plaque morphology, so we can decide what type of, if we need to, what type of atherectomy system to use. Because we're fortunate enough here, since we're not in a hospital system, we get to pretty much have all the bells and whistles that we want. And so we have a lot of options that we can tailor to each patient's condition. Any
pitfalls to getting access? Anything that you experienced a lot early on that you kind of was able to work out that you could suggest for a young guy trying this?
So I think for IR guys, it's not really much different than sticking a radial artery. Obviously there's a huge radial first movement. So most IR guys are doing a lot of stuff from the wrist. And so it's not much different, both from a depth standpoint. Now in the, posterior tibial, kind of the more proximal up the leg you get, and depending on the amount of calcification in the artery, it can get a little more challenging because that thing's going to roll around on you quite a bit. So on that, it just takes some practice. ATs are a little easier because you got the tibia right underneath it, so you can kind of pin it to it. But definitely, the more calcified the vessel is, it's going to give you a little more challenge. But yeah, a lot of it's just practice and having and developing. If you don't have them, then developing, good ultrasound skills. Actually seeing the needle tip enter the, the artery, not just watching tissue move and hoping that you're over the top of it.
Yeah, and if you can get a lot of tumescence in there with the local, it sometimes stabilizes that calcified vessel, so it doesn't roll on you as bad. So that's a little bit of a trick sometimes.
Yeah, I remember one of my first ones I did. The thing I was worried about, because the DP was so diseased, that I kept going higher and higher into the AT, and I was starting to worry that if I could cause compartment syndrome or something if my access site was bleeding. Is there any words like that or going too high in the AT or PT?
Yeah, you can have. I've had one compartment syndrome out of all those cases that I just fixed here at the OBL with some local anesthetic and stuff, and did a fasciotomy, and they did fine. It was AT distribution. So it's always a little concern. You have to just clinically watch. I don't think it really has much to do, because if you go halfway up the leg on the AT, the other halfway up is about the same depth. So we just try to stay that halfway down on AT.
Yeah. Okay. So in terms of like other potential complications, dissection, spasm, and we just mentioned, basically rupture or bleeding. Are you finding those less very rare? Is something to be, obviously careful about, but any suggestions to, help prevent spasm dissection?
Sure. So kind of like you're saying, we use nitro pretty liberally around here, both on your initial stick and our cocktail, but also on the way out, because you'll get some spasm in the artery that you accessed. And then there's times, you'll say you've pulled the sheath and they're holding pressure, and you come back and their foot's not looking super great, and you try to put a Doppler on it and you're not hearing much. And it's because you get spasm right at the access site. And most of the time you give it 15 minutes, come back and their foot's bright, perfect flow, and you got a bounding signal. If you ever have a little issue, I've had maybe 3 times where I put a little nitro paste over the top of it, and where the access site was, and same thing, 15, 30 minutes later, patient's doing great. Pulses are great all the way down into the toes. So other than that, I haven't really had too much of an issue. Obviously, we have a ton of ESRD and diabetes patients here, so a lot of calcified diseased tibial arteries to begin with, and so they're pretty rough just from the initial go. So, but no, we haven't, from a dissection point, not really, unless we're purposely, we try not to go subintimal if we can, and especially in the tibials. I just don't feel like they stay open as long. but sometimes it's inevitable. And but like most of the time, you're able to cross intraluminal and stay intraluminal.
Yeah. So getting into what the capabilities are, obviously angioplasty is being done below the knee, but tell me a little bit about what kind of atherectomy devices you're doing from pedal access, and also even stenting. I mean, I saw Jim stent a common iliac from the pedal, which was pretty impressive. But just I want to get into like the capabilities and what you guys are doing.
Yeah, so there's really not a lot of devices that we can't put through a 5.6, either one of those three brands of sheaths. So we below the knee, we again look at plaque morphology with IVUS. And depending on what that is, if it's more thrombus and less calcified, we'll use a laser, either a 0.9, 1.4, or 1.7. All of those go through a 4.5 French, and 2.0 goes through a 5.6. So, and the appropriate size vessels are listed for those. So, and that same thing applies for the SFA. As far as atherectomy goes, we have CSI devices. We have Phoenix or Spectranetics, Philips device, and those are the rotational atherectomy devices we have. And then we have laser we have the laser 2.0, and then the laser that has the tip that moves around a little bit better for ISR. So we have all those tools in the box, and which you never find at a hospital. So I think that's always good to have whatever you need. I think that for iliacs, we are obviously extremely careful. I think we have a very low complication rate in our space because of IVUS, and we measure those specifically. We don't overdilate, and we are always ready. When we're doing an iliac, we're always ready to put a 6.7 Terumo glide in, Terumo glide in, and be able to take a 7 VBX in at any time and dial it up to, at least 12 if needed, the iliac. So those are things that we have done, and we are ready to do with just a quick little sheath change and fluid support until we get there to fix it. So I think those are all things that you have to be ready for in this space. And if it's important that if this space is going to survive, you have to be ready for those kind of things in order to take the best care of patients.
And so when you're putting those larger sheath sizes in, are you keeping an eye on the clock and kind of making sure that you don't have that pedal artery occluded for very long before you decide to change access sites for whatever you're doing?
Well, I think you're going to find that arteries occluded regardless.
Right.
You put a 4.5 in, because you'll do a shot through the sheath and you'll get collateral flow distal to the sheath that you can see that's still open. And that's what we're obviously monitoring heparin, how much heparin we're given during the cases and all those, and as well as the nitro and all that, trying to minimize any kind of thrombin, because we're definitely, you're going to be occlusive, especially when some of these vessels, average size is probably a 3 in a tibial. And they're a hell of a lot smaller than that whenever you first start and highly calcified. So you're going to be occlusive now. And like you said, so when we know or have, we know there's going to be inflow disease too, or at least for me, half the time I have them prep the groins just as well. And then just in case emergency, we have a whole pack. Team knows everything that's going to, if we have a concern for any kind of rupture, we've got everything already waiting, ready to rock and roll, or we can get that taken care of. Luckily, we haven't really had any issue with that. Just like you said, I know the iliac thing freaks a lot of people out, especially trying to do it from the foot. But if it's a case that's really high risk, heavy calcium, super stenosed, there's a very high likelihood that you're gonna crack something and have an issue. Well, then, at least for me, that may not be a case that I'm going to do here. I'm going to take it to the hospital. I'm going to make sure that we have the support we need and get femoral access still and do that. So we're not complete gunslingers.
Right.
We still are, the patient's health is still always the forefront of what we're doing and making sure that what we're doing is safe. So
morphology of the plaque's really important. I think that at the end of the day, we have a really large series of, TOs, iliac TOs that are, easily fixed from the foot. And I'd like to get that published sometime soon. I think that it's a great way to keep somebody from having a fem that gets infected. And, that's a nightmare in my world. So I think at the end of the day, it's a great way to fix people if you can get it done. And we don't hesitate to pull out reentry devices, which are our reentry device of choice is a Pioneer device. So I think we have a low threshold for opening that device also.
Yeah. So once you've fixed the lesion, just talk us about, everybody knows how to close, groin access. How do you close pedal access, and talk us through, recovery for the patients, how long they're sitting in recovery, because I do think that this is one of the best benefits of pedal access.
Sure. Yeah, so I think both of us, we typically give a little nitro before at the very end of the sheath. At the very end, we'll do obviously a retrograde run through the sheath, make sure still the tibials look good and everything's nice and open. And then we typically give some nitro just for dilatation purposes. And then I would say the mass majority of the time, they just hold pressure. So we'll take the patient back to the room. The nurse will then pull the sheath there, and then we're continuously monitoring with while pressure's being held with Doppler distal, making sure that we've got flow. Just like if you were holding up pressure on a fistula or something, we obviously don't want to be occluding it. So, and then after that, pressure's probably held 15, 20 minutes at the most, and then those patients really, we start kind of dangling their leg off the bed at about an hour or so, hour and a half. And then most of them are out the door within an hour and a half to 2 hours. So.
Yeah, it's usually a 90-minute protocol we have. And obviously puts most of them are ready to go in 60 minutes. And the beauty of it too, is when they come back, they've ordered their box lunch from the deli down the street, and they're up eating. They're not laying flat on their back and a nurse holding pressure on their groin. So they're sitting up eating while either there's a radial band on the pedal site, or there's 2-finger pressure with documented distal flow. And I keep talking about these papers, but we're getting there. We're private practice, so it's kind of hard to compete with the ivory towers. We got a really nice paper of a look at 400, almost 500 cases that we did duplex on post-pedal, and proved that, the waveforms distal to stick site were all really good. So, at the end of the day, that's what people really want to know. If this procedure is safe, and right. And we intend on proving that. So.
Like many others, I was scared to do more harm than good with the whole pedal access thing, and especially working in the outpatient setting. It just seemed to have so many benefits, and I've heard stories of patients who've had both pedal access and femoral access, and they come back to see their doc, and they might need another intervention, and they literally demand pedal access just because of the their patient experience is so much better. And so I think from an outpatient setting, it just has so many benefits. But getting started, I didn't want any bad outcomes. So I was very particular in terms of my case selection. And the best starter case for me personally was it was an obese patient, kind of a hostile groin, and, had isolated, tibial disease. And it just, it was easy to get in. It wasn't easy, but it was relatively easy to get in, balloon angioplasty, do my post injection and be done. And so I think that's, to me, was the ideal case to start out with. Do you guys have any suggestions on people who want to get started or maybe a little bit hesitant?
Yeah, you nailed it, Aaron. I think at the end of the day, those people that are, they're just high risk to stick a groin, and the radial's an option if you talk to Terumo, but man, the radiation difference is drastic, to say the least. But I think that at the end of the day, your ideal candidates for your first cases are 2 or 3 vessel runoff and a total SFA with an ulcer. Those are your best ones to practice on. So, the below the knee disease is good. There's a lot of techniques that we try to teach when the docs come about up and over from PT to AT or AT to PT or interosseous, either one. And so we do those also without sticking a groin. But at the end of the day, the best cases and the most satisfying cases are the ones you can't get through from the top, but you just fly through them from the bottom, and you've healed up an ulcer. So those are really good cases. Now, when you're a critical limb ischemia center of excellence, or you that's what you want to be, you don't see a lot of those. But at the end of the day, those are really good cases to practice and get a lot of confidence with.
Yeah. And so what do you guys do about, pedal loop revascularization? Are you going up and over from AT to PT? How are you guys handling those kinds of cases?
Yeah, so a lot of times, just like you said, we'll either if you stick the AT or PT, we'll then go up and over and down the opposite, all the way down into the foot and into the pedal loop. Now, if I can't, or there's for some reason just their anatomy, it's too steep, whatever, you just can't get a good mechanical advantage on it. Then that's one I'll probably stick the patient antegrade femoral or SFA and come that way. But most of the time we're able to do it from that PT access and come up and over and treat everything from that.
You talk about the collaboration, I knew what a microcatheter was, but that seems like cheating now that Blake showed me all those things. So, it's really easy to get, even with steep angle stuff, it's really easy if you've got the right microcatheter and the ability to shape it to do that technique. So those are great things that I've learned from him. As far as
and we found some certain catheters that make it easier to get it, because a lot of people say, "Well, how the heck am I going to get up and over?" So we have a 90-degree Berenstein that will clip, make it shorter. I'll use like a sauce, and I'll just cut it off to where it just makes it's kind of like a mini rim, and use that to be able to get up and over. So it hasn't really been much of an issue, honestly, of getting up and then going back down the opposite artery and then getting treated what you need to.
And if any companies want to sponsor us, and we'll all three go together and be happy to build them catheters if you want.
Well, besides visiting you guys, any other resources for guys out there wanting to start this that you know of?
So I think that as far as industry goes, we're on both of us are on the teaching faculty for Terumo, Philips, and Spectranetics, which are the same, and Abbott. So if you use any of those products in your toolbox, you will be able to get to us as industry does it anytime you want. As far as there's courses all through the year, and if we can help in any way, obviously we'd love to help. At least give you another opportunity to treat your CLI patients. So.
Yeah, and then we occasionally have time or offer to give presentations at different conferences. And then obviously anyone can contact us at any point. Obviously Twitter's a huge part of it, but we're more than happy to always, someone calls with a question, what do we like to use in a certain instance or whatever, we're obviously always there and willing to help in any way we can. So.
Well, cool. Well, that's all the questions I had. Do you guys have any words of the wise, any closing remarks?
Yeah, I mean, for me, coming as an IR doc, some people are going to be like, why the hell would you join forces, with a vascular surgeon? And I'll be honest, I mean, there's a huge benefit. Like I said, I got to see it firsthand in my fellowship, but I mean, at least it happens every single week where I do an angiogram on a case, or I get access and I'm going through and I'm like, you know what? I don't think this is a great endo revasc case. I think we're going to end up jeopardizing future bypass options or treatment options. Well, then it's great for me as an IR doc because I've got a guy right here as my partner that we go over cases all the time, go over imaging, say, hey, from a surgery standpoint, what would what are your thoughts here? And so I think from a patient care standpoint, it's great because there's a lot of places where they don't have that. And so you feel a lot bigger push to be able to, or to go ahead and try fixing someone into vascular because that's, the option that you have when maybe that may not be the best option. So for me anyway, it's been great. It's been good just to continue to always understand too, what's his, from a surgery point of view, like what's he looking for? What's he thinking for future treatment options also. So.
Well, hey guys, I really appreciate you guys coming on the podcast. And again, it's a unique setup you guys have. And I hope that we see more of it, more collaboration amongst the endovascular specialties in the future. And I just want to, again, thank our audience for tuning in. And also thank you to our sponsor, RadPad. So that about wraps it up, guys. Thanks again.
Thank you.